Assalamu alaikum wa rahmatullahi wa barakatuh. And greetings. Thank you for being here. It's so wonderful to see your faces. There's some I know, some I don't know. My name is Ameedah, Rashid. I'm a clinical social worker. I've been in practice for a little over 35 years. That sounds better than the real deal. And yes, I am a Wolverine. From way back, that's where I met my other half. That's also where I started working with women. And that's the area that I work particularly in is women and children, particularly women who experience trauma. And I started in the Flint area, which we all know is on the map now. It wasn't on the map then. Working with what used to be called rape, now called sexual abuse. Then it didn't exist then. I'm dating myself. But I stayed in that area and worked primarily with trauma as it affects women and children. And of course, I progressed, and not so. I still do that, but I've worked primarily I have a private practice, have had for many years. I also have a practice where I work with children. It's called Family Life Enhancement Resource Consultants. We work with children that are preschool and school age experiencing emotional and behavioral health challenges. I do that with my other half, who's in the front here, Dr. Rashid. I think you heard him in the morning. He's a psychologist, and we kind of do some things together. But the work that I work with women is my practice is called Cycles. Cycles stands for Claim Your Change, Life Empowerment Strategies. I also, because like I said, I've been around a while, and I wanted to work primarily with Muslims, and I made a dua a long time ago that Allah would flip my script. So instead of working 95% people of other faiths, I would work maybe 50-50, 60-40. Now I work probably 80-20, primarily with Muslims. And I think what is probably the prime of my life, because I've come with a lot of experience. But what I'm going to talk with you today about is called Trauma-Informed Practices, an Islamic perspective for Muslim women and children. And I should say, I'm going to just start by doing something that you don't see a slide for, and that's to really talk about, we all hear about trauma constantly. We know people talk about what trauma is and what trauma-informed is, and I'm going to also talk about what trauma is. But trauma, I think it was said earlier this morning, is a reaction to. But let me just say what trauma-informed care is. Because trauma is a reaction to an event that happens in a person's life that is unexpected, that's overwhelming, and that puts them in a position where they cannot really successfully use the normal adaptation to stress that's entering their system. It can be physical, it can be emotional, it can be, usually it's all of the above. But we often use a term called trauma-informed care, and I'm using that particularly because I'm not just talking to mental health clinicians. I'm talking to all of us who touch the lives, particularly now we're talking about Muslims, but I could easily be talking about anybody. Because the reality is, without a doubt, the majority of women in the world experience trauma. The majority of children experience trauma in various ways, but I'm just talking today about trauma. So when I talk with Muslims, when I talk about trauma-informed care, let's just say first, there's no clear definition of exactly what that is. Different people say it's different things. The field tries to come up with a definition, but the term itself really comes out of the work of Harris and Fallout, and it really wasn't really introduced until early the 90s, really in terms of an actual term. And so it means different things in different places, and that's important because in a medical setting where I work 2 days a week, a psychiatrist might be involved, a physician might be involved. But when I work in the middle of the week, when I'm not working in those settings, I might be involved, an imam might be involved, families might be involved, and none of those, if I'm doing crisis intervention, none of the above. It might be me, myself, and I in the field with some other workers. So, but what it really refers to is a framework. It's informed care, and its strength is really, it's a strength-based framework, as opposed to the medical model, which is a disease model, that you're dying, let me give you some medicine so you can die better. This is, and I say that in that way because you're really looking at someone that really came out of Michigan's clinical program. And my orientation in the 70s was very different. And it really was medical. It really was very Western. But it has evolved to a point where I don't see intervention in that way. I think it has to be holistic. And it has to be built on the strengths of people. And most important, which is consistent with this model, it has to be culturally responsive. And it has to have a clear understanding of the responsiveness to the impact of the trauma. Now, when we talk about trauma, I want us to think about traumatic stress because we meaning these people, that all of us in this room, we're more likely to experience traumatic stress in people. And it occurs often when a person has witnessed events, maybe an extreme life event, something's, I should scroll forward. Before I get to what trauma is, before I get to the facts here, because this kind of jumped out at me, because these are traumatic events. Let's look at them. Now, this came out of a study. There are people here, by the way, that are representing this poll that was listed, the ICPU poll. This is very new, but it shows, again, 42% of Muslims and children, K through 12, report bullying. Bullying is a traumatic event, at least it can be. It's not always, but it can be, and it often is. 38% of Muslims are most likely to express fear for their personal and family safety from white supremacist groups. Well, if you've ever experienced a contact with a white supremacist group, matter of fact, has anybody in this room ever had that experience besides me? Yes. Okay, has anyone ever had the experience of witnessing, experiencing, or being aware of bullying? Wow, more hands. Okay. Well, the majority of non-white Muslims, 56%, black Muslims, and 60% Arab Muslims, 63% Asian Muslims, report some frequency of race-based discrimination, irregardless of your race. Have you ever experienced discrimination because of your race? Raise your hand if you have. Raise your hand if you've ever experienced gender discrimination because of who you are as a woman or man. Because these are the kinds of things that we talk about are called microaggressions, and sometimes they're not. Sometimes they're actually traumatic events. More often than not, they are things that just occur daily. But it's also important to know that we're in a whole new phase in this country of trauma, because twice as many Muslims are really likely to be stopped at borders, like maybe from the US to Canada, you're going to a conference, just because you're Muslim. Not because you are, and more likely than not, if you are a female Muslim. Females are more likely to be stopped than males. Now, why is that? Maybe it has something to do with this picture here. Growing up American as a Muslim. One thing that stands out in all of these pictures to me is that they're brown. But more importantly, what stands out is they look different than the standard of norm. And when we talk about the two places and the two groups that are most likely to experience trauma based on these looks, they're going to be to the right, children. So schools that you've heard all through these workshops are struggling with how to address the needs of Muslim children, but also because they're women. The impact of Islamophobia is also another area in which trauma is a very, very big part of people's lives. So when I talk about trauma, before I even look at the stats, which you can read, let's just say, I just want to digress for just a moment and say, what is the difference between trauma and traumatic stress? Well, when we think of stress, really, stress can really be quite normal. It's a reaction. It's usually internal or external, and usually both, to something that, some type of stimuli that will disturb us. Maybe you have a test. Maybe somebody doesn't like the way you look, but you're used to that, so that doesn't, you kind of do that in your undergraduate experience. That might be a little bit more stressful. Stress in a family where getting a graduate degree is part of completing your identity as a whole person may be a lot more traumatic for you than it would be for someone who is just trying to move on and improve themselves. Testing for someone else who's been told most of their lives that you don't test well, your people don't test well, you're not going to test well, we'll let you take the test just to see how you do. That may be a little bit more stressful for somebody to say, who in the world would that be? Well, the majority of people of color, in particular African Americans first, but now you're in the same boat, are experiencing that. If there's a quota for your group, and only so many are going to get, testing becomes stressful for you. But does it become traumatic? Probably not. But if one thing that we see in Muslim communities is the impact of Islamophobia, which really is a layering. And I want to make sure that I make this very clear, because Islamophobia in and of itself, I do not believe is always stressful or traumatic. I think for some people it is more so than others. But I think if you've had an aggregate of cumulative stressors, if you are from a background in which crime is part of your reality, in terms of drugs are part of reality, in terms of if you are more likely to be deported or you have that kind of fear, I think then Islamophobia means something different to you than, say, it might mean to someone who has a professional career. And I can just say, you see how I'm dressed, right? This is not new, okay? You may see me in a game and I may have on something a little bit, but you'll know I'm Muslim. But I was black long before I was Muslim. So to me, to get stopped in the middle of the night, you don't know Maryland, but in the rural parts of Maryland, Hagerstown or someplace near the border of Pennsylvania, Klan country, is a lot more stressful than wearing hijab at the airport. So Islamophobia for me is a little different. But you might not know that if I come into your environment as a result of domestic violence. That may be something that to you looks like the stressor. And I think it's really important when we talk about trauma-informed care that we really look at the kinds of things that women in particular are experiencing. We look at anxiety, we look at depression, we look at impaired concentration. Are we looking at the results of Islamophobia? Are we looking at the results of physical abuse? Are we looking at the results of historic child abuse and child trauma? Are we looking at the results of having your husband incarcerated or fear of your son being incarcerated? All of those things are cumulative, and all of those things are stressors. And what takes the person to the tipping point may or may not be what we think it is, and often it is not. But more often than not, it is probably not Islamophobia. At least for many of the people that many of us may be seeing. But we really don't know until we are able to really interface with the person so that we can take the kind of information from them to see if what we're looking at is marital distress, which most women, by the way, are experiencing in the Muslim community. I'm talking about Muslims now, so don't think it's just Muslims, okay? We're just talking about Muslims, okay? But marital distress is one of the big ones. So is abuse, by the way, on different levels. What children are experiencing is anxiety. It's rampant. And some of it's about being bullied, and some of it's about dealing with issues at home that have a lot to do with domestic violence, or they have a lot to do with parental conflict or cultural conflict. But there's still anxiety, and then sometimes it is about how they're being reacted to. What about how we deal with this in terms of being informed, in terms of providing informed care for traumatized children? Well, first of all, we recognize that if a child is experiencing trauma, what they're in is survival mode, and what does that look like? It looks like fear. It looks like anxiety. It looks like hyperactivity. it looks like anger. It looks like rage. So we try to respond to that, which informed care, through kindness and compassion, which is sometimes very difficult to deal with if you've got 20 kids in a weekend class. Those of us are doing that. Or if you're doing a group, or if you have them in a session, or if you haven't got your room set up. But those are things that we make sure we prepare for before they come. We also understand the transitions between activities can trigger a student into survival mode. So something that looked very ordinary is not ordinary if a child is experiencing trauma for many reasons, some of which we'll hear about more, some of which you've heard others. I've just kind of brushed some of them. What can we do? How many of you use mindfulness and practices of mindfulness in your practice, if you're practitioners, in your work, with your students? How many people actually are using that? Wonderful. How many people know that there are a number of urban schools I know of, I think suburban too, that are using this as part of their curriculum? But they are. And we can teach parents how to do that, but more importantly, we can encourage children to do this as something that's very normal. I put in red print because I want you to hold on to this, is to take care of yourself, because one of the biggest things we have to deal with in providing trauma-informed care is providing trauma-informed care for ourselves, which is being kind and compassionate and taking care of ourselves. And having someone you can respond, who can help us respond. How about strategies for stabilizing stability? I told you the name of cycles and what that stood for. That's why it's called that. Life empowerment strategies. Stability, helping her control the urge to run away, fight, freeze, trauma. This is what we see when people are in a state of trauma. Helping her understand that by teaching her strategies. If you do mindfulness, then you probably do focused breathing. If you pray, you probably do focused breathing. If you dhikr, you probably do focused breathing. These are things we don't even think about, but these are things that we can use strategically. Safety, increase the sense of safety by having and identifying and seeking out people who the person can trust. And sometimes it's not the masjid, sorry to say. Sometimes it's a sacred space. Sometimes it's another space. Sometimes it's your office. Sometimes it's something you create. Focusing on strength and not weaknesses. What can the community do? Establish weekly spiritual and social support activities that do not have to be in the masjid. They would be great if they could be. That's really the ideal place. That means that you've got some alliance with a very awesome imam and some boards. Provide Muslim self-help and stress relief facilitated by counselors and coaches. And if you're not one, there are plenty of those out here who can help you become one. Establish healing food, education, demonstration. Now, what do I say? Food, holistic. One of the best ways to deal with trauma is just not always with words and talk. Trauma is stored in the body, so there have to be ways to release that. There have to be activities to release them, but what you put in also has something to do. You look at the vitamin 12, look, B12 of people. There's some medical science to this, but what do we know and what do we not know has a lot to do with nothing other than us bringing stuff in with people who do know. Identifying a team of trained leaders to coordinate stress management teams. This is going on, by the way. I know Adams does it, and others do. And finally, providing retreats. Retreats that are not just get away, have fun retreats, retreats that are focused on bringing people like yourselves. I hope this has been very brief, but I hope that it kind of opens up the rest of what you'll hear and support.
First of all, I'd like to thank the Institute of Mental Health for allowing us to speak on this important topic, which is understanding the mental health needs of women who experience female genital mutilation or cutting, which I'm going to probably be referring to as FGMC from now on. And also, I will be referring to those who experience this as survivors, because that's how they want to be identified.
Can you bring the mic a little closer, please?
Oh, sure. How do we change this? Over here? So I wanted also to thank and acknowledge my team at GW, especially the PI for the study, Dr. Karen McDonald, and our community partner and colleague, Khadijah Abdullah from Rahman. And I'd also like to acknowledge that this study was funded by the Department of Health and Human Services, the Office of Women's Health. Just before we start, I also wanted to make sure to state that although FGMC is a cultural practice, it's also been recognized as a human rights violation and a form of gender-based violence. So before I start, I would like to make a disclaimer that if there are any survivors in the room, information might be triggering. So feel free to take whatever means necessary to be comfortable. And those who aren't survivors, there will be information that's uncomfortable, but I invite you to be open, and these are discussions we need to have, especially if we are to support these women. So just a bit of a background on FGM. First of all, just want to know by show of hands how many of you know about FGMC? Oh, okay, then I'll be very brief. All right, so the WHO defines FGM as all procedures that involve a partial or total removal of the external female genitalia or any other injury to the female genitalia that is not medically necessary or is not done for any medical reasons. Again, it's a cultural practice that predates religions, it predates Islam, Christianity, and Judaism, and it is practiced globally, so it's everywhere. Pretty much. Predominantly 30 major countries have high prevalence, but it is everywhere, including the US. And it's usually performed on little girls, which the age ranges between 0 and 15 years of age, and it has no health benefits whatsoever. It only causes harm to girls and women. There are 4 types of FGMC. Type 1 is the removal of the clitoris or the clitoral hood. Type 2 involves the removal of the clitoris and the labia minora, or the inner lips of the vagina, with or without partial removal of the labia majora. Type 3 is when the clitoris, the labia minora, and the labia majora are removed, and then so the vagina is sealed shut, leaving a small opening for urine and menstrual blood to pass through. In some cultures, that opening is the size of a corn kernel. Type 4 refers to just general mutilation, which could involve pricking, pinching, stretching of the vagina, extension, cauterization, burning, and scraping. There are many health risks and outcomes involved with this practice. They're usually categorized into immediate and long-term. Immediate are the ones that girls usually experience that cause, they're so extensive that they could cause death, and which is a shock and trauma of the experience itself. Severe hemorrhage, severe pain, urinary problems, and the long-term outcomes are those that involve any problems with the urinary tract, infections, vaginal problems, scarring, menstrual problems, sexual health problems or dyspareunia, and pregnancy and childbirth complications, especially in cases with type 3, where there is a need for additional surgeries and openings during birth. But the most the least explored health complication is a psychological trauma that these women go through. So just to go over the stats real quick, today, globally, about 200 million women and girls have experienced female genital mutilation, or FGMC. And it is estimated that a little over 500,000 women in the U.S. are at risk or have undergone FGMC, so they are survivors. And this just speaks to the importance of prevention, but also the need for support for women who've already experienced this. And in the DC metropolitan area, it's estimated that there are about 50,000 women who've experienced this. So the objective was really to understand the health needs of these women in order to support them. So our methods were qualitative, so we took on a phenomenological approach. We interviewed women in the DC metropolitan area who were over the age of 18, and we did some recruiting techniques into the community. We visited, places of worship, so mosques, churches, community centers, different events, and recruited women who were willing to talk to us and speak to us. And we did our thematic analysis using both. So what I really wanted to emphasize here was, for many of these women, this was actually almost all of these women, this is the first time they had ever spoken to anyone about their experience with FGM and their needs and what they really wanted in terms of support. So it was important to us to make sure that their words and their voices were central to the analysis process and to the data presentation process. I'm not going to be reading their quotes that are on the slides, but I invite you to take a look at them, just for the purposes of time, but I just wanted to point that out so that we make sure that their voices are heard. So overall, we didn't focus on a specific country or culture or religion. So the women we spoke to had backgrounds from 12 different countries. So they were from East Africa, West Africa, the Middle East, and South Asia. The majority were had undergone type 1, and the age range of the women that we spoke to was between 26 and 82 years of age. And again, the women had experienced FGM at different stages of their childhood, but they were all under the age of 15. And the majority of the women we spoke to were Muslim, so about 84%. And the reason why I'm using percentages, even though this is a qualitative study, is because it's for purposes of confidentiality. So what we found was for women who've experienced FGM, this functions as a traumatic childhood experience that was seeped in secrecy. This was the overall theme, or the overall sort of overarching theme that came out from the data. And for many of these women, again, they've experienced this as children, and as the sister had mentioned, that children go through these traumatic experiences, and they need care when especially with something like this. There needs to be trauma-informed care in this process. Again, they were too young to understand, so they didn't understand what was happening. No one had asked them. They expressed that they did not ever give any consent, and they never had a choice in this matter. So again, with trauma-informed experiences with kids or adverse childhood events, the secrecy or this notion that they had no choice always keeps surfacing. Love from their families, but they do equate it with things like rape, assault, and being violated as a child. And so as a result, this trauma manifests in different physical and psychological outcomes, including anger, PTSD, and feelings of depression. To compound all these elements of trauma, there was a lot of stigma and misunderstanding surrounding sexual health in general among these women, especially within their cultures. So they weren't able to understand what happened to them as they were growing up, and also it was because they weren't allowed to speak about it. So it was always hushed and taboo not to talk about it, and so they couldn't really understand the health outcomes they were experiencing as they were growing up. And for many, they were also threatened not to talk about it. So They were told if you talk about it, your stomach will become bloated and you will die, or your mother will die if you talk about this. So never talk about it, never address it, and again, for many, the first time they talked about it was during our interview. And with these misunderstandings, although FGM was never addressed specifically, there were always these messages that they heard that this is going to keep you good, it was done to keep you calm, it makes you marriageable, and it's done to decrease your sexual desires. So these were the messages they were hearing, and to counter that, there was also this stigma of not being circumcised or not undergoing FGM was equated with being a bad girl, being too hyper, and being ostracized within the community. And this is within their own community, whether it was here in the US or back home. So coming into the US context, or the context that's outside of the communities here, there's the stigma and isolation that they experienced in that context, or the American context. Again, they were too young to make a comparison, and because they didn't know what life felt like before being circumcised or before undergoing FGM, and they can't understand what is normal. So they don't really know how to relate what they're experiencing to FGM, and so they cannot seek the help they need. And when they talk to their peers, when they see things on TV, when they hear about things or read things and going to college and learning about sexual health and health in general, they feel less than, they feel abnormal, they feel different, and they feel isolated and unable to seek the help that they need. And again, compounded within that were the fears and barriers stemming from the immigrant experiences. So there's a lot of shame around what happened. There's resignation that this already happened. There's gender reservations, language, and of course the concept of Islamophobia that keeps coming up, where should I talk about it? I can't talk about it. People will think something about my religion or about my culture. And they experience many negative experiences with their healthcare providers, and this causes re-traumatization. So there were women who, their healthcare providers, during their first care visits, they would make them feel odd, they would gasp, they would change the look on their face. There were women who, while they're having their first pap smear or first exam, their healthcare provider would call the whole hospital, come say, come look at this. So they were being put on display, and that served as a barrier to them forever seeking healthcare again and avoiding healthcare even during pregnancy, as they would wait until they're actually giving labor. And also, there's also the issue of being re-traumatized every time a child is born, every time they have a sexual encounter, and every time they're having pap smears or pelvic exams. So these things are avoided, causing health problems and problems within the family itself and with their relationships with their partners. So one thing that emerged strongly was that there is a need for structural support mechanisms among these women. Women wanted forums where they can talk and address this issue. Talking really helps. That kept being repeated because one thing, they wanted to break the silence. After talking about this, they wanted to keep talking about this, but at the same time they wanted it to be within a contained social and supportive structure and not within a structure that would expose them. And they also wanted to share concepts of how do I deal with the outcomes that I'm experiencing. Maybe their peers who've gone through something can help them deal with their menstrual issues, with their sexual issues, and things of that nature. But also there was also a need for trained healthcare providers because of their experiences with the healthcare providers that they had, and they wanted to seek more mental health support. So in conclusion, what we found was really the healthcare needs of women who experienced FGMC or FGM survivors is it's impacted by psychological trauma and all these misunderstandings and these negative interactions. And there's a definite need for programming that includes this targeted psychological support mechanisms that are really integrated into the primary health care that they're giving, but also within the community. So there needs to be a lot of community education to create these social support structures for these women.
Do you see me? Can you hear me? Does my feelings matter? Am I visible? I am so lonely. I am so afraid of rejection. I am so afraid to fall in love. If you know it's positive, would you walk away? My depression is taking over my soul. Suicidal thoughts, they're in my head every day, like a dark shadow over my body. Your stigma equals my depression, my anxiety, my PTSD, my shame. My mental health, it can't take it. I need you to see me. I need you to love me. I'm a person, I have feelings too. You're my community. Don't turn your back on me. See me for me, not my status. See me as a person and love me. I need you. Love me. A community is supposed to be built on rahmah and have mercy. So why? Why do I feel so alone? I'm just talking this, actually. So I just shared some perspectives and perceptions of Muslims who are positive in their reality. They face depression, they face stigma, isolation in their own community. They're banned from the masjid because people don't know or understand and are ignorant. I founded Rahmah to address these challenges, to provide a safe space for Muslims who feel they have no space, who have no voice, and are alone. I want to do a quick activity with you all. Do you have pens? Take your pen out. Look under your chair. There's a blank piece of paper. Now, this requires no thinking. Do not think. Just put words that come to your head. I'm going to say 3 words. I'll leave for a second.
No rushing for pens.
Oh, see, I didn't bring pens. That was my bad.
Who wants the pen?
Who needs pens? Everybody's good?
I need a pen.
Need a pen over here?
Oh, yeah. Anyone else need?
Okay, so I'm going to say one word. I want you to think, whatever you don't think. The first word that comes to your head, write it down. Are you guys ready?
Yeah.
Okay. HIV, start writing. No thinking, just start writing. Whatever words that come to your head, just write. Nope, you look at me, you're thinking. Just start writing. Whatever comes to your head. HIV. You're thinking of a word right now in your head. Just write it down. Yes.
One word or just
No, keep going. Keep going with words. Right. 1 word, 2 words, 3 words, 4 words. Just keep going. Writing words. You can think of blood, you can think whatever you want to think of. Just write it down on this paper. This is just a safe zone, judgment free. So write down your actual thoughts. Ten more seconds. Who wants to share what they wrote? I'll give you this microphone.
For HIV, I call unprotected sex, autoimmune, IV drug abuse, Africa, baby treatment. For mental health,
If you just say that again, I'm sorry.
yeah, all of them?
Yeah.
Okay. For HIV, I call unprotected sex, autoimmune, IV drug abuse, Africa, gay, and treatment. Okay. For mental health, I call treatment, substance abuse, depression, illness, crisis, diagnosis.
Thank you. Anyone else want to share theirs?
AIDS, death, sadness, pain, family, community, love, basketball, because I couldn't think of that basketball player. And then, yes, and then for mental health, pain, hard, stigma, misunderstanding, depression, anxiety, heavy.
Good. Anyone else? Beside the room. What do we see as far as correlation?
They're both stigmatized.
Mm. Say it again.
They're both
That word you
stigmatized.
said, stigmatized. Stigmatized. That is the connection between the two. You got right to the point. So HIV, stigmatized, so mental health. So what can we do as a community to address that? Think about, don't answer my question, think about it in your head. What can we do as a community to address the stigma that's in our community? Think about it. I don't want any answers right now. All right. So I'll jump right into Rahma. We have a shirt on time, a lot of things to show in here. So I chose the name Rahma because when I was in college, I worked in a hospital part-time as a student nurse. And I had a patient who was Muslim living with AIDS. Now I was shocked. This is my first time ever meeting a Muslim living with AIDS. In my mosque, we didn't talk about sexual health or anything. So I'm like, whoa, okay, hold up. We take a step back and I had to learn about this. I went to school, I got educated, I went on my campus, with AIDS Awareness Week, and became passionate about it. I came down to DC, interned at a local nonprofit, and I started Rahma because Rahma means what? Mercy. And mercy needs to be our guiding principle in what we do. So Rahma is my guiding principle in my day-to-day work, in my organization. And also, we started off focusing on Muslim communities only, but then I saw a need is in all faith communities. So this past year, we founded National Faith HIV and AIDS Awareness Day, and we had Muslims, Christians, Sikhs, Hindus, Baha'is, Buddhists, and Jewish people come together, talk about HIV and AIDS and raising awareness. I have a short video for you to see at the end. So just quickly, you can read these different things that we do: workshops, research, FGC, support groups, youth groups. We had a basketball tournament against stigma, keyword stigma, and they played games and won iPads and mountain bikes for playing. We had free testing on site. The kids really enjoyed it. We had a great time. Interfaith, we had a retreat. We were positive. They came from across the country to DC for a 3-day, 2-night retreat. Muslims who were positive. They came here. People who were suicidal, people who were depressed, people who felt alone. They came and found their family. And that really motivates me to keep doing this work. Our partners, we had Ameedah there, out there at the booth. They funded our youth program. GW, Islamic Relief, that's also been a funder for us. Other people, Advocates for Youth, Mental Hospital Center, ADAP Association, and we have more than that. Some more people, so we had booths at like ICNA, we've been at Adam Center right there, we had a little booth there, this is me talking at a masjid. We're just really trying to get the word out and really raise awareness. So for Faith Day, we had AIDS behind us, we had PEPFAR, Balm and Gilead, we're also churches. We really want to pull people together to unite in this very important topic and discussion. This is me. We had the first AIDS Awareness Day, August 27th of last year. So we're on stage, talking to the crowd. Oh, this is the video, but it just shows a screenshot. That's interesting. Oh, no, you don't want that. Sorry. I'm trying to go back. Why is it not playing?
Escape out of it, see if it shows up.
No. there's the video. I'm trying to find some sound real quick.
The bottom of the screen.
Oh, it's muted, yeah.
Okay, so here's the video from our first HIV/AIDS Awareness Day.
The national faith.
IR was there, just on relief.
The National Faith HIV/AIDS Awareness Day Walk and Rally. Let's put our hands together for this day. We're so excited to be here. We're so excited to be in this place, Freedom Plaza. No other place that I think would be more appropriate.
And look at you all here today. It really gives me hope, and it helps me to believe that you have the power.
So one of the reasons why we chose the start point for this march at the White House was to really galvanize this administration in the wake of anti-poor and anti-HIV policies so that they can begin to do their part to end HIV and AIDS. Otherwise, we run the risk of moving backwards years in progress that we've made, not only as communities of faith, but people living with HIV and AIDS, advocates, healthcare providers, and the like.